When I spoke to you previously, you mentioned, and this had not occurred to me until I spoke with you, that there's, demographic change in our patients and how our TGNC patients are younger and they may have undergone pubertal suppression and how that affects the skin available for a more traditional penile and virginal vaginoplasty. Could you share a little bit about how that has shifted your practice?
Yeah, definitely. You made a comment about sort of the demographic shifting. I would just say they're expanding in either direction. So yeah, a lot of adolescents presenting for surgical intervention, but also a lot of people that are like in their 70s sometimes coming in for genital surgery, and then everything in between. But the adolescents for sure present some unique challenges. Obviously, there's great evidence supporting pubertal suppression for a whole variety of benefits. But the one thing that is very new is genital surgery in someone that has underwent pubertal suppression. Not so much an issue in someone with assigned female at birth anatomy that undergoes a phalloplasty, because we're creating something with free tissue transfer or flap anyway, but a much bigger issue for an individual that's undergoing a penile inversion vaginoplasty, because we use all of that tissue to basically create the vulva as well as line the internal vaginal canal. And as a specialty, those of us that do a fairly high volume of genital gender affirming surgery, we've maybe done a handful of pubertally suppressed adolescents as a field, and no one's published on it yet. We're just putting our first series together as we're kind of learning and figuring out what works. But it's really changing things because you don't have enough tissue to line the vaginal canal. So you either have to take a skin graft or take skin from elsewhere or use some artificial product. The way that we're dealing with it is by using a robot. Regardless of technique, whether it's standard penile inversion, intestinal vaginoplasty, or robotic, lifelong dilation is pretty much the rule. We've seen patients coming back even 20 plus years out from a vaginoplasty that have something happen in their life that they just don't dilate and are having sex for a year, and they will lose a lot of depth. Doesn't tend to be a width issue so much, but definitely will lose a lot of depth. So we do kind of say, lifelong dilation if you want to maintain as much depth as possible. And then a lot of patients just from psychosocial issues and the dysphoria that they're experiencing, or just blatant transphobia in society, may have not had the opportunity to have a sexual partner. And more often than not, there's been almost no genital engagement in terms of self-stimulation or masturbation. So then trying to assess things like erogenous outcomes after a surgery when someone's never had an erogenous experience in their life is incredibly difficult because they don't really have a baseline to compare it to. And then, post-operative care, anyone knows that's seen a post-operative vaginoplasty patient is really intense. And we're kind of asking someone that is younger and hasn't really engaged or done much with their genitalia to all of a sudden do this like really aggressive relaxation for dilation. And it's just a huge ask. So we're finding that to be a barrier almost more so than, yes, the surgery is technically challenging and demanding, but I think we're developing pretty good strategies to deal with that. But what we really need is like a robust support system. And I think there's going to be a huge role for therapy peri-operatively in terms of even preoperative genital engagement, trying to have those conversations, preparedness, readiness, support through that postoperative protocol, because some of the early challenges are getting someone to successfully dilate that's never had to engage with their pelvic floor musculature and is maybe 17, 18 years old. It's hard.